Good evening, everyone. I'll be presenting this journal, which is the results of a randomized double-blind placebo-controlled phase 2 study, which proposed iptacopan as an alternative complement pathway inhibitor for IgA nephropathy, which was published by Hong Zhang et al. In Kidney International in January 2024. Uh, IgA nephropathy is the most common form of glomerulonephritis with a global incidence of approximately 25 per million per year. There are regional variations in occurrence and even biopsy practices, and there is a higher prevalence rate and higher risk of progression to kidney failure in Asians. 15 to 40% of patients develop kidney failure within 10 to 20 years from diagnosis. So the main risk factors for progression to kidney failure is presence of persistently high proteinuria of more than 1 gram per day, presence of hypertension. Uncontrolled hypertension is associated with a rapid decline in renal function, reduced GFR and rate of eGFR decline, and MES-C score at diagnosis, predominantly the T2 score, which has been found in the study by Alexander S. et al. This was the first South Asian prospective longitudinal observational study. That's the Gracie-Ghani study that was conducted. Our center was also a part of it. Why is there a need for newer therapies in IgA nephropathy? Despite advances in the understanding of pathogenesis, there are no disease-specific therapies yet. And a large number of patients have persisting proteinuria and are at a higher risk of disease progression despite optimal supportive care. Newer therapies include SGLT2 inhibitors, dual endothelin receptor antagonists that are available now and approved for therapy in IgA nephropathy. Immunosuppressive therapies, actually the effect on proteinuria is not very long lasting. And once the immunosuppression is stopped, the effect on proteinuria also is reduced. And the toxicities that are associated with immunosuppressive therapies actually limit the role of immunosuppression in IgA nephropathy. So, in the talking about the pathogenesis of IgA nephropathy, we have a four-hit model. So, whenever there is an antigen exposure to the mucosa-associated lymphoid tissue, there is the activation of the innate cells, which then activate the specific CD20 B cells via the BAFF and April uh, uh, pathway. There is a T cell and T cell dependent and T cell independent processes in formation of CD20 IgA1 positive B cells. These then convert to plasma cells and then go back to the mucosa and generate IgA1, which is degalactolysated or poorly glycosylated IgA1, which is circulating in the blood. So these actually, there is generation of autoantibodies against this poorly glycosylated IgA as well. And these antibodies bind to the antigens and form immune complexes. So this is the third hit in the pathogenesis. And once the immune complexes are formed, these actually deposit in the mesangium, and there is downstream activation of the inflammatory and the complement pathways, leading to glomerular and tubular injury in patients with IgA nephropathy, leading to proteinuria and renal dysfunction. So the role of complement system in IgA nephropathy, there are certain genetic factors and environmental factors which are responsible for increased synthesis of the GD, the galactose deficient IgA1, and the increased concentration of degalactolysated IgA1 in the circulation. They have a tendency to deposit in the mesangium, and also they have an intrinsic property to activate the complement pathway. So in the complement pathway, they predominantly activate the alternate pathway and the lectin pathway by mannose binding lectin, and this actually prevents the this actually causes increased activation of the C3 convertase and the downstream activation of C5a anerphylotoxins and the membrane attack complex, which are responsible for the glomerular injury. So we have various drugs that are actually acting against the complement system, which are in phase 2 and phase 3 trials as of now. We have the narsoplimab drug that which acts on the mannose binding lectin serine proteases and prevents the prevents the activation of the C3 convertase. We have a pegcetacoplan, which prevents the alternative pathway at the level of C3 upstream. And we have iptacopan, which is the drug that we are talking about today, which inhibits factor B, which acts as a catalyst for the amplification loop, which is responsible for the activation, persistent activation of the C3 convertase, and for downstream formation of the C5a and membrane attack complexes, which lead to immune cells activation and glomerular injury and podocyte injury in patients with IgA nephropathy. So, briefly about the treatment of IgA nephropathy, we have non-immunological treatments in the form of RAS inhibitors, SGLT2 inhibitors, and endothelin receptor antagonists. Immunological therapies, we have broad-acting immunosuppressants, which are being used for a long time. That's systemic steroids and MMF. However, MMF has proven to be non-beneficial in IgA nephropathy. We have the Nefigan and Nefigard studies, which Nefigard study is still ongoing. The Nefigan study has this is studied oral budesonide. It was a phase 2 trial which targeted against the formation of antibodies against the galactoside-related IgA. We also have B cell and plasma cell target, that is rituximab bortezomib, which have proven to be not beneficial in IgA nephropathy. And BAFF and APRIL antagonist, we have the atacicept, which binds to both and prevents the activation of the B cells and generation of the antibodies. And these have actually shown decreased proteinuria by around 30% in phase 2 trials. And we have a APRIL inhibitor, that is sibeprenlimab, which is being currently studied. So, coming to topic proper, we have iptacopan. Iptacopan binds to the FB of the alternate complement pathway, which plays an essential catalytic role in the formation of C3 convertases, which is responsible for amplification of the alternative pathway, which is blocked by iptacopan. It is an oral proximal complement pathway inhibitor and binds to FP and inhibits the complement pathway. So this is the site of action of iptacopan, where it binds to factor B and prevents the amplification loop in the C3 in the alternate pathway at the level of C3 convertase. So, coming to journal proper, this is a results of a randomized double-blind placebo-controlled phase 2 study to propose iptacopan as a alternate complement pathway inhibitor for IgA nephropathy, published in Kidney International in Jan 2024. The aims and objectives of the study was to evaluate the dose-response relationship of iptacopan versus placebo, and to evaluate the safety and tolerability of this drug in patients with IgA nephropathy. The study design, it was a multi-center trial, included patients of all ethnicities. It was a randomized trial. It was blinded to the investigator, patient, as well as the sponsor. It was placebo-controlled dose-ranging study with an adaptive design phase 2 study, and was funded by the Novartis Pharma. The study was conducted in two parts. Parts one was to establish initial proof of concept based on pre-specified criteria. The pre-specified criteria was to establish a 20% reduction in proteinuria with this drug. That reflected the existence of an initial dose response relationship. So part 2 of the study was after the proof of concept was established based on the recommendation from study data monitoring committee based on the interim analysis at the end of part 1. Part 2 had a additional dose arm to increase the precision of the estimate of the dose that achieves 90% of the maximum drug effect. And part 1 and part 2 studies were analyzed together to provide a confirmatory dose response information as a post hoc analysis. So the inclusion criteria was patients with biopsy confirmed IgA nephropathy, and the biopsy should have been done within the last 3 years, and estimated GFR of more than 30 ml per minute per 1.73 meter square, as per CKD-EPI equation. These patients were actually continued to run in period of 3 months, and the patients who had persistent proteinuria defined by urine protein more than or equal to 0.75 gram per 24 hours after completion of a run-in period, despite maximum tolerated doses of RAS inhibitors. So all these patients were on RAS inhibitors for at least 3 months, and their blood pressures were controlled as per KDIGO. And these patients were eligible for randomization. And all these patients were vaccinated against Haemophilus influenza, meningococcal and pneumococcal infection. And the kidney biopsy and MES scores were determined by a study pathologist to maintain uniformity. Exclusion criteria, those patients who had more than 50% crescents or biopsy were excluded. Those patients who were treated with immunosuppression or who had a steroid exposure in the last 90 days. Patients who had previously received iptacopan or other investigational drugs at the time or within half-lives of the administration, or within 5 half-lives of the administration of the drug, or less than 30 days, whichever was longer. All transplanted patients who had received either a solid organ or a bone marrow transplant were excluded. Those who had immunodeficiency diseases or who were serologically positive for HPV or HCV chronic infection were excluded. Those patients who had any surgical or medical condition affecting the pharmacokinetics of the drugs, pregnant and lactating mothers were excluded. Those who had donated plasma of more than 200 ml within the last 30 days were also excluded, and women of childbearing age unless they were using effective contraceptive methods. So randomization, all the patients were actually stratified by ancestry into Asian and non-Asian, and the method for randomization that was used was interactive response technology. There were 4 arms to intervention, 3 arms of various iptacopan doses and 1 arm for the placebo, and all these drugs were administered as oral capsules. Part 1 evaluated doses of 10 mg, 50 mg, 200 mg twice daily of iptacopan, and part 2 had a additional dose arm that was 100 mg twice daily as a pre-planned component of an adaptive study design. So this was the study design. All patients had a run-in period of 90 days or 3 months, and they were randomized into 4 groups, 3 groups into 3 different dosages of iptacopan, that is 10 mg, 50 mg, and 200 mg twice daily, and placebo, and they were followed up for another duration. They were given the drug for 3 months and followed up for another 3 months. Part 2 of the study included another dosage outcomes were the change from baseline in urine protein creatinine ratio from first morning void or 24-hour urine albumin to creatinine. The change from baseline in complement biomarkers such as plasma BB levels, soluble urine and plasma C5b9 membrane attack immunosorbent assays. We had additional biomarkers that were analyzed as well, including serum ex vivo triggered alternate complement pathway activity, which was a semi-quantitative assay called the WheezLab assay, and plasma levels of FB were also looked into. Pre-specified analysis using pool data from part 1 and part 2 for 3-month time point, and part 2 data alone was used for 6-month time point analysis, and post hoc analysis was used for dose response effect estimation on urine protein creatinine ratio reduction at 3 months. And adverse events were thoroughly monitored throughout the study. So coming to statistical analysis, the primary methodology that was used was multiple comparison procedure methodology, which used a 2-stage approach involving mixed model of repeat measures for analyzing the change from baseline using log transform UPCR at multiple time points. Dose response assessment was examined for the existence of a dose response relationship at one-sided 10% significance level using the MCP model, which is again multiple comparison procedure models. And it implemented multiple contrast sets based on log transform model estimated means at day 90. And 6 dose response shapes were used for pre-specified analysis. A multiplicity adjusted critical values determined from the joint multivariate T distribution of optimal contrast. The p-value that was used for statistical significance was less than 0.1 the study. The dose response curve was predicted using the parametric bootstrap model, and the results were presented as model estimated mean ratios to placebo with 80% with using 80% confidence intervals. And there was a pre-specified one-sided type 1 error rate of 10% for all efficacy analysis. And post hoc exploratory analysis was done using a parametric bootstrap model using pooled data from part 1 and part 2 of the study. Safety data was summarized using descriptive statistics, and all of this data was analyzed using an independent external team and an external data monitoring committee. And sample size determination. So part 1 planned enrollment of 48 patients, assuming a dropout rate of 20%, and the sample size of 40 patients in part 1 aim for at least 85% power, assuming treatment effect of 50% with a standard deviation of 0.7. And part 2 sample size also estimated at the power of 80% with a one-sided significance level of 10%. So this is the patient disposition. We had 261 patients that were screened, and 112 patients were randomized into the treatment arm, into the arms of the study. In the part 1 of the study, we had dosages of 10 mg, 50 mg, and 200 mg that were studied against placebo, and all of these patients completed the study duration of 3 months. In the second part of the study, as a part of the pre-specified analysis, we had a addition of iptacopan 100 mg arm as well. And here we had 5 patients who had dropped out of the study. One of them dropped out because of protocol deviation, and 3 of these patients dropped out because of adverse events. In the iptacopan 50 mg group, the adverse events that was noted was a mild COVID infection in this patient, and in placebo group, there was a COVID infection, and one of the patients had a inhalation of chlorine gas, and they had to be excluded. And one of these patients had discontinued treatment in the 100 mg BD group. So the baseline characteristics of the patients, all of them in the treatment groups were matched by age and gender. Most of these patients were male, around more than 50% of patients were males. And we had all ethnicities of patients that were included in the study, predominantly being Asian and white population. All of these patients had received supportive care by use of ACI ARBs for at least 3 months during the run-in period. And the baseline urine protein creatinine ratio was not similar across all groups. In the 200 mg arm, the urine protein creatinine ratio was 1.3, which was similar to the placebo at baseline, but the proteinuria was much higher in patients who were in the 10 mg, 50 mg, and 100 mg arms. The blood pressures were all controlled across all arms according to KDIGO recommendations. And some of these patients had used immunosuppression. The complement pathway biomarkers at baseline, all of these biomarkers were within normal limits except for the urine C5b9 levels, which were high in these patients at baseline. So were the participants blind to the intervention? They were, and the investigators as well as the people who were assessing and analyzing the outcomes were blinded for the study. And the study group similar at the start of the randomized, but they were similar. And apart from the experimental intervention, they received the same level of care. All of these patients had received the same supportive care with ACI ARBs for 3 months prior to run-in period. So coming to the results, there was a significant reduction in urine protein creatinine ratio that was noted at 3 months duration, and maximum reduction was seen with 200 milligram twice daily dosing. There was a clinically meaningful reduction. That means to say there was a pre-specified value of more than 20% reduction in urine protein creatinine ratio reduction as a clinically meaningful reduction in proteinuria. So it was observed only in the 200 milligram twice daily group arm where there was around 23% reduction in proteinuria compared to placebo. However, there was a reduction in proteinuria across all arms, but significant reduction was seen with 200 mg twice daily arm. And post hoc analysis of pool data from part 1 and part 2 of the study showed a 40% reduction in proteinuria at a confidence interval of 80% with a MCP model estimate of 0.6. This is the post-hoc analysis of part 2 study alone, where there was a significant reduction in proteinuria in the 200 milligram twice daily uh, uh, arm of the study. And this is a table that is showing the mean urine protein to creatinine ratio per treatment group at baseline and at month 3 and 6. So all of these dosages showed a reduction in proteinuria, but the significant reduction in proteinuria was observed across 200 milligram. The maximum reduction in proteinuria was noticed in the 200 milligram twice daily um, of iptacopan. And change in EGFR, all of the patients who had receiving iptacopan, their EGFR remained stable. However, there was a decline in EGFR of around 3.34 ml per minute per meter square in the placebo arm, whereas all of them remained stable in the treatment arm. And in part 2, the EGFR remained stable up to 6 months in all the treatment arms as compared to placebo. Change in complement biomarker levels, it was observed that the plasma BB levels were reduced significantly compared to the placebo at 3 months. And there was a small increase in F factor B from baseline that was observed at around 12% at 3 months and 23% 6 months with 20 milligram BD dosing and above. And in the Weiss lab assay, there was a dose dependent inhibition, as we can see. And purple graph shows us the iptacopan 10 mg BD dosing arm. So there was a dose dependent inhibition of the alternate complement pathway by iptacopan. There was also a rapid and marked decrease in C5D9 levels at 3 months with 200 mg BD dosing of iptacopan. Plasma BB levels, the Weiss lab assay predicting the alternate complement pathway activity and C5B9 inhibition was sustained at 6 months in patients who had received about 10 mg BD dosing of iptacopan. Safety outcomes, all of these patients had only mild to moderate adverse events, and the most common adverse events that were seen were headache and back pain in these patients, followed by diarrhea and nasopharyngitis, which were all not very significant. So where the effects of intervention reported comprehensively, yes. Was the precision of the estimate of the intervention or treatment effect reported? Yes, with 80% power. However, do the benefits of experimental intervention outweigh the harms and costs? Yes, so, all the patients had mild to moderate adverse events, and there were no deaths that were reported. None of them had severe adverse events. So definitely the intervention is the benefits are the phase response effect of proteinuria reduction also continued through 6 months of iptacopan treatment, and all patients had already received baseline and supportive care with controlled blood pressures. Proteinuria reduction with iptacopan can be accepted as a surrogate marker for improved long-term kidney outcomes. EGFR, however, remained stable throughout the study duration. However, to assess the slope of decline in EGFR or stability of EGFR, we need a longer follow-up and larger number of patients need to be recruited for robust assessment. However, this is one of the endpoints that is being studied in OPLOS phase 3 trial. Complement pathway inhibition, iptacopan targets the upstream and proximal part of the complement pathway and prevents the activation of the amplification loop, which is responsible for 80% of the complement activation, which was effectively suppressed by ex vivo triggered alternate pathway activation in a dose dependent manner as seen in the graph by Wieslab assay. And there was a strong and sustained inhibition of terminal pathway with reduced urinary C5 to C5b9 levels that was observed. The strength of the study, it was a well-designed RCT and the patient, investigator, as well as the sponsors were blinded. Provided a reliable and robust estimation of treatment effects of iptacopan. Broad range of ethnicities and patient population were included in the study. It was an adaptive design, provided the opportunity to terminate the trial early for futility and to adjust sample size and number of doses after interim analysis. And there were less adverse events that were noted, and there were no deaths or serious adverse events that were noted in the study. The limitations of the study, there was a smaller sample size. It was not powered adequately and was powered at 80%. 80%. It excluded patients with EGFR of less than 30 ml per minute per 1.73 meters square. The duration of the study was short and could not assess the EGFR slope adequately. And the 6-month treatment effect was studied only in part 2 of the study. And this study was just done to test a dose response, but was not set up formally to test the efficacy of specific doses. So it cannot be applied broadly. And the cost and availability of this drug right now, it is costly and in the experimental stage. So that also would be a limiting factor to use in patients. So can the results be applied to our local population? It was a study conducted across multiple centers with multiple ethnicities of patients being studied. However, smaller sample size may be a limitation. And would the experimental intervention provide greater value to the people in your care than any of the existing interventions? Yes, the results of this phase 2 trial actually seems promising in the treatment of IgA nephropathy with the newer mechanism of action blocking the alternate complement pathway. However, we need phase 3 trials to test the efficacy and safety of these drugs, and cost and availability of this experimental drug also limits its utility now at currently, and data on comparison of these drugs with existing non-immunomodulatory and immunomodulatory drugs are actually lacking. So what are the evidence that we have currently on iptacopan? We have the APPLAUSE trial, which is an ongoing phase 3 RCT for iptacopan in IgA nephropathy, and the results are yet to be released. Iptacopan currently has been approved for use in PNH, which was approved in December 2023 with phase 3 apply and upon trials. The side effect and safety profile has been similar in apply and upon trials. And can corroborate with the findings in our study and the current study as well. Iptacopan has been studied in C3GN as a phase 2 trial by Wong et al., which included around 27 patients with 16 native kidney and 11 recurrent kidney transplant cohorts, and they have reported a significant, that's around 45% reduction in urine protein creatinine ratio from baseline with a p-value of 0.003 and 2.5 times reduction in C3 deposit score with normalization of C3 levels. And the side effect profile with no deaths being reported in C3GN cohort as well. So these are the various studies that is being conducted on IgA nephropathy, the newer experimental drugs currently. We have iptacopan in the APPLAUSE IgA nephropathy trial. And it is being planned to recruit 450 biopsy-proven IgA nephropathy patients, including patients from Asia as well. And primary endpoints are similar to the study where they're looking at a log transform ratio to baseline in UPCR at 9 months and total EGFR slope estimation over 1 year. And we have the Artemis IgA nephropathy trial that is studying narsoplimab. Narsoplimab is a monoclonal antibody against mannose binding lectin serine proteases that activate the lectin pathway of the complement system. We have sparsentan, which is the PROTECT trial, which is looking, all of these have primary endpoints of change in urine protein creatinine from baseline. And this sparsentan is actually comparing with ARB Besartid. We have a Align trial, which is studying atrasentan currently, and Nefigard trial, which is a phase 3 trial that is planned to study oral budesonide and IgA nephropathy. And the visionary trial, of which our center also is a part of it, which is APRIL inhibitor. We have the sibeprenlimab, which is a humanized IgG2 monoclonal antibody that is being studied. So to conclude the study, this is the first study to show that selective inhibition of alternative pathway in patients with IgA nephropathy results in clinically meaningful reduction in proteinuria. It was observed that there was 23% reduction with 200 mg BD dosing and 40% reduction post-hoc analysis at 6 months. Effect of proteinuria is expected to translate to treatment benefit on eGFR slope. This is a well-tolerated drug with oral dosing and rapid clearance. It has also shown strong inhibition of complement biomarkers, which may be deemed as renoprotective. And currently, we have phase 3 trials that are underway. So this is the summary slide. Thank you. I'd like to thank Indian Society of Nephrology and our department for giving me the opportunity to present.
Thank you, Dr. Sriraksha. That was a nice presentation. Now I invite the panelists, Dr. Satish Balans and Dr. Srijit sir, to initiate the discussion, and request the audience to please feel free to post all your comments and queries in the chat box, and we'll be taking it up subsequently. Sir.
Yeah, thank you, Arun. And I just want to congratulate Dr. Raksha. You did a very good presentation, and you have summarized the study properly and all the major plus points and the minus points. But there are some problems. It's a small study. It's a phase 2 trial. In the methodology, which I would like to say, one is that the statistical, this thing mumbo jumbo is too difficult to understand. Multiple comparison models and all that. No? Why didn't they do a simple thing? I mean, the advantage you said because of the statistical was because you could have stopped the study at any point for futility. After all, it's a 6 months trial. Why would you want to stop for futility? You can always measure the points at 6 months and then get away with it. So all you need to know the UPCR at 6 months, the UPCR at 3 months, and you can make a comparison between the groups. Simple as that. So that is one of the problems I have with the methodology. You have anything to say about that?
So actually, they have used the mixed comparison model here. So if we actually take absolute values, then we'll have to assume that there would be a definite reduction in protein. But here this was testing the dose response relationship. So in that, I think this would be better whether the patient can, I mean, whether the drug will achieve a dose response effect or no, we do not know. So it is, I think that is the reason that they probably have used this.
Actually, what I'm saying is, suppose you look at the final data, you showed the table for supplementary data, yes, and you showed that, the 200 milligram group had a reduction from 1.3 to 0.8 at the end of it. Other groups did not have that great a reduction.
That's significant.
So that value gives us a very good bird's eye view of the whole trial. We need not go into the mixed comparison model on things. I don't know. Usually what happens in industry-sponsored trials is this. Their methodology here, that conduct of the trial is good because their randomization, everything they do perfectly because they don't want to be faulted that it's a poorly randomized trial. But when it comes to methods, they make it difficult. So that is where they play, so that they give the maximum possibility that the trial should be interpreted in their favor. That is where the manipulation can occur. So that's why, because I don't understand it, maybe what you say is right, but I'm not really sure. I'm not an expert in statistics. I can't say that this is a bad one or a good one. Maybe they meant it well, maybe they meant it well. But one good thing I can say is that if you look at the data, it correlates with what they're saying. So probably it doesn't make much of a difference. But I still have a lingering suspicion that they made this in order to make their results look better. Fortunately, they had a good result. But if the results had not been good, probably they could have put that into their favor. That is one of the things I had. The second point I would like to make is about the 10 milligram dose. Probably it is not effective. It did not reduce the factor B levels. It did not reduce the factor B levels minimally, and the C3B9 levels also, whereas others all reduced, and quite well they reduced. So probably it was effective in there as far as the mechanism is concerned, and it was effective as far as proteinuria is concerned. So that's the second take-home point I would like to take from this. Would you agree with that? The 10 milligram dose. I'm talking about 10 milligram
Yes, the
dose.
10 milligram did not show any significant reduction either in proteinuria or in the complement factor level. So
Yeah.
might not be a effective dose.
So that is one of the problems. The third point is the randomization itself. They had a stratification thing. They stratified in Asians and non-Asians. So that limits the power of the randomization because you have already two separate. That's why you notice that 50% are Asians, 50% are non-Asians in the study. Whereas you look at other things, for instance, male sex was overrepresented in the placebo group. They had more than 70%, whereas the other groups are nearly 50 across. So we do not know if males respond badly to placebo. Maybe females respond better. So that may be one reason why this has but there is no data on that. I can't say that. I can't fault them for that. This happened. But because a small trial, I don't know whether you can really get better than that as far as the baseline groups are concerned. So that is another criticism I have. So these are the major things I found to the trial, therefore, that limit the conclusions. So I would like to have a much more simplified trial. It's easier to understand. So statistics is the problem here. Srijit, you have anything to say on that?
Regarding this specific comment, I'm switching on. I'm keeping my video off because I am having network issue. I hope you don't mind. So regarding the specific comment you made about the analysis part, my understanding is that this is a validated and recommended analysis model when looking at dose-response relationship.
Okay.
Even though it is supposed to be a more reasoned sort of thing, I'm not very good at statistical technicalities. But then my understanding is that I personally will not find fault with that sort of analysis because the analysis is indeed not simple because there are multiple arms, and basically the intention was to look at dose response relationship. So that actually makes it complicated. And that is probably the reason why they used that particular analysis model. I personally think that we need not necessarily find fault with because that was used, and that I think probably doesn't really invalidate the observations made. But then the question is the real question is that no, there is the reduction in proteinuria demonstrated was less than 25%, 23% in the study. And so whether that first question is whether reduction in proteinuria is a valid surrogate marker for renal protection or improvement in renal outcomes, which I think has had enough debate on that. So we will not go into that. But this was around 23% reduction. So that is one, I think, criticism which can the quantum of reduction of proteinuria. But then my own response that will be this was added to standard of care. Right, these patients were in fact on ACE inhibitors ARB. Even though I think if you look at the details, not all of them were on the highest dose of ACE inhibitors or ARBs. So it looks like they were some of them were not on the highest dose recommended, but they were except I think one patient everybody was on. Is there any fault with that? You would find Dr. Srireksha that with regard to the standard of care,
But all of these patients were actually in a run-in period of around 3 months. But 3 months to actually look at the response to RAS inhibition again is questionable. So we don't know whether that would whether it was a response to the RAS inhibition or was it response to iptacopan. It's too short of a duration to say.
Yeah, but we do have data from S inhibitor ARB trials, how long it takes and how much is the magnitude. So again, I will not really fault that design. But my question was not that. As of now, what is the standard of care? Is it just S inhibitor ARB or
No, we have SGLT2 inhibition also that has been now included
yeah?
in the
So
standard
that
of care.
okay. So that again, that is one issue. As of today, the standard of care in somebody with IgA nephropathy, some amount of proteinuria, relatively stable or gradually progressive disease will include SGLT2 inhibitors. But the standard of care in this study didn't have that. Probably because the study was designed before SGLT2 inhibitors got approved for that indication. But then that is something which I think we need to keep in mind. Uh, because this is a journal club, I would like to go in a couple of other issues with regard to how we go about interpreting the study. So one point, you actually did an excellent job of analyzing the study. After each point, you have actually used a checklist to say whether the design and all was appropriate. But one thing is about the research hypothesis. When what is the basis for this study? So that part, I think, I think you could have made one additional point. When you look at the research hypothesis of this study, what was the research hypothesis? Was it appropriate, and what was the basis for that?
Yes, so the basis of it was the complement inhibition, the activation of the alternate complement pathway in IgA nephropathy. So this was a
So
drug
what is
that
the evidence for that is what I am asking. What is the evidence that the study has significance if we have some data showing that complement activation indeed plays some role in the pathogenesis of IgA. So my question to you is, if you have some data on that, then you can think, yes, yeah, let us try some intervention in the complement pathway. So what is the evidence available as of now
So
of the role of complement activation in the pathogenesis of IgA nephropathy?
This drug was actually studied when PNH and other atypical HUS. These are all other complement disorders which had complement activation, and it was found to be effective. So it was hypothesized that this drug could also be effective in acting against the complement activation in IgA nephropathy. So
that is not answer
been
my question. My specific question. Please listen to that question. What I am asking is, what is it is true that it was already studied in PNH and other conditions, but what is the evidence that complement activation plays a role in the pathogenesis of IgA nephropathy?
I'm not really sure.
It is there in the article. Okay, so I think that it is there in the article. I didn't notice that in your slides. That is why I brought it up, because there is already some evidence available that there is evidence of complement activation in IgA nephropathy. There is data on that. Okay. The other thing about the study design, you mentioned about this being a double-blind RCT, but then you mentioned a term adaptive. What do you mean by an adaptive study design?
Adaptive is like they had a pre-specified, like they were changing the dosage in part 1 and part 2 of this study arms, like different dose arms were added. So that is why it was an adaptive study.
Now, my question is not specific to this study. My question is in general. When you say an adaptive trial, what do you mean by that?
So based on the interim analysis, whether to continue the study or to discontinue the study, whether if at the end of interim analysis, if the study is proving the dose response or the primary endpoint, then they would progress with the second part of the study. So that's why it was that would probably be called adaptive study designs.
Yeah. So there are two aspects to it. One is that it is not about termination or two stages. It is basically about making modifications in the study design or the intervention based on the data you get as you are going along with the trial, right? You look at the data, but then you can say that, okay, this we can do for all the trials. Let us start a trial. Let us look at the data, and then based on the data, can we change? Would you call it an adaptive design? That will not be an adaptive design, because in a true adaptive design, you have to pre-specify that what will you do, and if you, what sort of analysis will you do? And when you find something, then what modification you will make? So when you do that, when it has to be pre-specified, it cannot be done as we go along. Okay, so that is one other important aspect. So the point is, these sort of trials are a lot of thought goes into the study design, because if you have to define what sort of modifications you will make based on the data available, you really need to be have applied your mind on what exactly you're trying to do and what you're trying to find. So the other one was about the statistical analysis. It was too complicated for me. We already discussed that. The point again I wanted to make was that this study design seems to be a more recently described analytic model when you are looking at dose response relationship. So that, even though it has the technical details is beyond me, I think it is not really something which can be taken as a real shortcoming of this study. The other one was about the type 1, type 2 error. You did mention that. Is it appropriate or is it inappropriate? What do you think?
Just less higher error rate was taken in this. That
Yeah,
type
so
1 alpha
again,
error of 10%.
yeah, usually, but like again, I'm not a
20%.
statistician. There may be people who know better. Usually, it is around, by default, it is kept as 5%.
5%.
Yeah. So this year it is kept as 10%. So that actually increases the chances of type 1 error. So that is one thing which again may not invalidate the study, but then that is again something which I think we need to understand about the study design. Looking at the other thing, what do you think? What do you think is the that is about the study technical part of it, how it was designed and how you interpret it. The study seems to be showing that this is a drug which seems to be working, right? But what do you think is the significance of this finding for in the treatment of IgA nephropathy? What is the implication? What is the significance? This is you already mentioned that it is a new target to address in IgA nephropathy, but again, is there anything more to it in its significance?
Sir, actually, there is no it just targets the amplification loop, though, so that the C3 low level activation is still persistent in these patients. So that is one newer thing that is there with iptacopan.
Yeah, so this basically it spares the classical pathway, right? So it's not that the complement response will be completely knocked out. So there is still some, even though this is knocking out the alternate pathway, there is still some amount of complement activation which can happen in response to stimuli which goes through the classical pathway. So that is probably what the reason why we are not finding, even though the data is limited, the infections are not really huge. Okay, all of them were vaccinated. If you look at it, there were at least three type of vaccines were given. A couple of the patients got prophylaxis, and it was because it was not part of study design. It was left to the investigators to do that. So only 2 got prophylaxis, but the infection rates were not high. So I think that is one important. It's not only that it is a new option; it seems to be an option which is addressing a pathway which doesn't knock out your immune response completely in the complement system, and the classical pathway still can be activated, still can work, probably give some protection, right? And what is the other very, very, I would say I find it very significant, very useful about this particular
decrease in the urinary MAC levels, sir. So that
it is not only urinary,
was
actually,
and
both
even
the serum as well as urinary biomarkers were quantified, and you can see that by day 12 or so, you are able to demonstrate a significant reduction in these things. So basically, in addition to the traditional way of monitoring the GFR, monitoring the proteinuria, looking at the histopathology, now we have a less invasive and likely more objective it has to be validated. It's too early to say, but this was not something which was available earlier. So this opens up the possibility that you may be able to monitor the disease activity or the activity of the drug. So that is another point about whether the drug is really working or not. Here, biomarkers were studied and it showed a dramatic reduction in the C35B in the urine and the serum activities and all. So that again adding to the value of your observation that this drug seems to be really working. Whether it will result in reduced ESRD progression is a different issue that has to be demonstrated.
Yeah.
But biologically, it seems to be having impact. And in the preliminary study with phase 2, limited number of patients, you are showing a reduction in proteinuria, and compared to the placebo, the GFR seems to be remaining stable. Very preliminary data, but I think there are two important takeaway from this from science point of view. One is that this is a new target which doesn't completely knock out the complement pathway. So infection risk may be less. And the second thing is that this treatment option gives you the chance of actually monitoring the disease activity or the action of the drug. So that's all I have from my point. Dr. Satish, if you have additional...
Yeah, just a cautionary note I would like to add is that even though this study shows there is some benefit, let's say we have measured only surrogate markers. We have proteinuria, and we have known that this, you must notice that the drug is not like RASI or something like that. It claims that it is going to treat the disease proper, not just the downward, that proteinuria and other things like RASI and all supposed to reduce the proteinuria, reduce the fibrosis. But this actually tackles the basis of the disease according to the hypothesis that they have generated. So based on that, if you look at it, the results show that there is only a reduction in proteinuria and there's reduction in complement levels. So reduction in complement levels does not mean the disease is actually being corrected. The disease may be beyond complement. You may have other factors which are acting upon IgA nephropathy. So we know that there is a reduction of the complement parameters. We know that there is reduction of proteinuria, but whether it actually modifies the disease, probably we'll have to wait for stage of the phase 3 trials, because this does not give us that data. And only that, you look at the GFR data, it is still not, in this study, small study, we do not see a meaningful increase in the GFR. But placebo GFR has come down in time, which is not good also, because the studies have shown that placebo, also the so-called placebo standard of care, actually, the GFR remains stable. In here, the GFR has actually come down by 3 ml in the placebo group, but it has remained the same in the other groups. So we don't have data as such, but still very promising. And probably if the phase 3 trials come out and it's effective, it's good. So with that, we would like to tackle the questions on the board.
Yes, sir, we will take a couple of them at least. So the first question was from Dr. Venkatesh, asking about whether 20% reduction of proteinuria is a good target, especially when the baseline proteinuria was less than 2 grams, and how it will be clinically relevant in day-to-day practice in our country.
I myself asked that question. Okay. So, but the point is that this is in addition to standard of care. Okay, these people were the blood pressures were controlled, and these people were on ACE inhibitors or ARB, and beyond that, you are getting another 20% reduction. So, I would say I will be reluctant to dismiss it, saying that this is insignificant. Maybe with more data on the proteinuria as well as the progression, it's possible that this is significant. I would think that it's possible. I would not dismiss it.
Okay. The next question was from Agarwal, sir. This was the point whether using the mean value of UPCR rather than the percentage causes a interpretation to be misled. That is one. And whether what was the course of the patient prior to being included in the trial, because the patients had a biopsy within 3 years. So whether they had progressed in the recent past before they were included in the trial.
I think it's a good point that he makes about urine PCR, the group as a whole, because if you look at it, if some patients may have different, but they have given the standard deviation for the groups. I think it was about 0.6 for the 200 milligram group and 1 for the placebo group, if I'm not wrong. And that shows that there is a good amount of variation in the individual urine proteinuria reduction. So maybe some people do well, some people don't do that well. And again, it depends upon the initial. You must remember that 70% of the patients had a T1 in this group. So they all had fibrosis, significant fibrosis. So how far this is going to be effective, we can't be sure.
I think the same questions about proteinuria reduction as also from Dr. Pooja from memory. And we have a comment from Dr. Sampath Kumar sir that serum complement levels are normal in IgA nephropathy, and though we see C3 deposits in contrast to SLE or MPGN also. So whether it is only a local activation is some question which cannot be answered, and there is a missing link because of which Vocapin should not have a major effect in this condition. And one question was on whether that.
Arun, before sorry to interrupt you.
Yes, sir,
In
no
fact, the serum complement levels actually, if you, I'm telling from memory, there are studies showing C4D deposition in IgA nephropathy, and I think around 20 or 30% of IgA nephropathies are actually supposed to be having low complement levels also. It's not that it is not observed. The problem is that if it is an IgA nephropathy, we usually don't check. Honestly, at least in our center, we don't really ask for complement levels in them. So there is a subset of population. It's also important to understand that complement activation may not be a significant component of pathogens in all cases of IgA nephropathy. There seems to be a subset of patients where the complements actually may be low. But then it is also possible that it is predominantly renal tissue activation of complements, and it may not reflect on the serum levels also. So it is not as very black and white as it seems, because there is some data showing that complement levels may actually be low.
Okay.
Thank you.
Yes, sir.
Yeah, that point there also, one more thing is that if you look at they have measured the factor B levels of C5b9 levels, all of them are in the normal range in the beginning of the study. But they have come down with treatment. That's the only thing. So initially the complement is not that activated, systemic complement. So maybe still only a subset complement is activated.
And one question from Dr. Temetro is whether the relationship of proteinuria reduction was compared with the baseline MESSI scoring. I don't think so. It was.
I don't think
they had mentioned anywhere about the MESS scoring, though it is a prognostic marker.
It'd be nice to have a MESSI scoring and the prognostication based on it. But then MESSI scoring has never been used for treatment. So we can't really judge on the basis of that.
Yeah, but it will be challenging, because if you look at the inclusion criteria, I think biopsy could have been done 3 years back also. It was within last 3 years. So it's possible that somebody had biopsy done 3 years back or 2.5 years back, and then you are recruiting now. So now, unless you have baseline MESS score in all of them, that will be very difficult to, I would say, study.
And I guess another comment from Dr. Jitu that the very less rate of drug discontinuation probably makes it a very attractive option for further studies. So I guess these are the major questions which we had from the chat box with regard to this trial. So any final comments from the panelist, Dr. Shyam sir?
Yeah, no, I think both the panelists and the presenter, they did present very well, and good discussion. So at the end, I think we need more data, and probably the question which I thought already been discussed here, this is not the standard of care. If you see the trials like DAPA-CKD and other trials, there's a consistent 30 to 40% reduction in proteinuria with after ACE inhibitor and ARB. So that's very important. And we are talking about 20% reduction with all other newer therapies. So I would say the real utility of these drugs would only be there once you have both these treatments, ACE inhibitor, ARB, and then you add on SGLT2 inhibitors, and then you add any of these drugs, and then you see, because these drugs are not only means there would be side effect, and they're costly drugs. So I would say we need more data and the standard of care. That's what my take on this.
Srijit sir and Satish Balan sir.
Yes, I think most of the points have already been summarized. The only thing to say that this looks promising. I hope that the phase 3 trials are more successful, because this is a drug which is targeting the action of the IgA upon the kidney. So if even if the IgA is acting elsewhere in the body, in the kidney, it will be protected if this drug is effective. So that may be a very good thing to do. And probably another thing I was thinking is a combination of budesonide, which prevents the generation of this abnormal IgA protein. And along with this, maybe a good combination, because you treat the disease at this base and you treat the side effects in the kidney, and probably that may be a good way to do it. But all depends upon whether these benefits are really evident even on a phase 3 trial.
I agree with both of you that I do believe that this is highly promising, is what I would say. Looks highly promising. And the other advantage which I think we forgot to discuss was that this is an oral drug. Unlike most of the other complement inhibitors, this is an orally administered drug, and the whatever available data seems to be quite promising. And other thing I find very exciting or interesting is that we are able to monitor the biomarkers are available to monitor the treatment or the response. So looks quite promising to me. Thank you for having me in the Journal Club, Arun, and your team. Thank you.
Thank you,
Thanks
sir.
for VP.
Thank you all. Thank you all. So we'll be continuing our monthly Journal Clubs on the third Wednesday of every month. So request all of you to actively participate in it, and we'll try to probably have the mixed comparison model being discussed by a statistician in the next months also, because it had generated lots of discussion. Thank you, Dr. Sri Raksha, and all the panelists and all the attendees also. Thank you.
And
Thank
finally,
you.
to Raksha, also congratulations for a brilliant presentation.
Thank you, sir. Thank you so much.